the other component to this is much the same talking points as we had a few minutes ago about the patients and the departments that are going to see advantage from this are also the ones probably with the lowest call volume and out in the middle of nowhere, that there might be some hesitance on the medical director side to allow to do it from a just, I hate to say skill, but from, just from the sheer number of runs that department may encounter, right?
Yeah, but from a medical, I might authorize like supervisors to do it, right?
Yeah, right.
So someone that is either that's their B job and they're on a high performing department. Otherwise, like if AJ was working at one of those volunteering, I'd trust him to do that procedure. Or some of the other agencies, like that might be not every ground beater is going to be doing that, but like from a supervisor level, that's something that they can arrive on scene and then do that advanced procedure.
And those are people that you can schedule in for training sessions and keep that skill level up.
Correct. And people that I probably have a much better and closer relationship, and I know how they practice their medicine than just someone else that's on the team.
Mm-hmm. So anyway, that was always kind of been my take on this. Is going to be a special teams, isolated case use. I don't think we're going to see just a broad, a scalpel for you, a scalpel for you, a scalpel for you.
Well, I mean, and critical care flight medicine is a perfect example, right?
Yep.
They should be trained to do that on scene because they're arriving to the terrible scenes.
Right?
Yes.
Already are. Yep. Actually kind of were under the auspices of the nurse ahead of time. Now it's, honestly, we dotted some I's, crossed some T's, and it just makes reporting easier because the paramedic can legitimately do it and document that they did it, not as I assisted the nurse in doing it. That medic may have done the whole thing.
Nurse was yelling at me as I was doing it.
That's right. So ultrasound device utilization to be performed as authorized by the local medical director. So originally this was ultrasound for venous access, and it's already morphed into
fast
at your discretion.
Yeah.
So I guess everybody's, we can do a fast scan. We can look at this. We can look at that. Your personal thoughts on that? I wonder if is the training and the ability and the spend worth the outcome, right? Because I'm already identifying the high risk cases and getting them to the right place. Does additional confirmation of my suspicion without the view make or break the case?
I think would be beneficial. There's going to be a huge amount of costs associated with this to do this. At best, you're looking at a few $1,000s. We'll use $3 to $5 to get a device that will allow you to do this. There's some ongoing costs there. So there's obviously costs associated with ongoing training and maintenance of those devices. I personally love ultrasound. I'm not ultrasound trained. I don't love it that much, but I do use it in my practice in the emergency departments. We use, in contrast, those handheld devices that cost let's just say $5,000 for easy math. The devices we're using in the emergency department are $100,000 to $150,000, and then in contrast to the machines that are used by radiology can go $300,000 to $500,000, and they make really pretty pictures. I'm very jealous of those pictures, even compared to my $100,000 device. And obviously, you still can see what you're doing with those handheld devices. And it's currently escaping me. I had this conversation recently with somebody, and I think that there's a place for it, obviously in critical care medicine, to the point of I can do a lung exam and identify a lack of sliding, so maybe earlier intervention to see that I do have a pneumothorax on that side. I could intervene in that case. I would maybe even argue that if you're doing a fast exam and you're seeing blood, you're seeing free fluid in the abdomen on a fast exam, that might be an indication. Let's say they're entrapped, that you're calling the helicopter to be like, I need blood because I see free fluid in the abdomen. Yeah. So I see that there are kind of cases for it. It's going to be that a good paramedic or even basic to know this person's sick and they need to go to the trauma center.
I like the idea of having one more further confirmation for death too, though. I mean, cardiac standstill is
that I can see as
I like that idea.
If we can figure out, and everything's possible, but if we can figure out how to get that image to
Stream
get
that.
overread by the physician,
Yeah.
and we have certain protocols now that
Yeah.
I can send EKG images and get overread by the doc. That would be something that'd be great to, hey, send me a video clip
Yeah.
of what you're seeing from cardiac activity. The way I can validate
Validate,
that
yeah.
the patient isn't certainly
I mean,
dead.
We've called patients all the time in the field and got confirmation from the doc, but there's always that I would love one more piece here, because if I go home and they wake up,
Then you hear those horror stories.
you
Yeah,
do.
yeah,
I mean,
absolutely, right.
we talked about one with your overdose a while ago on one of these episodes. Not
Yeah,
yours per
not,
se,
not
but
mine, but it was in Ohio.
yeah.
And it goes along with that in that case, and all the cases where we talk about that trust gets violated, right? And when the doc on the phone or your medical director is asking for more information, and I'm taking on some new agencies right now and having that discussion and making the joke like, hey, the monitors are audio recording you when it's really not. I'm like, that's it. I'm one of my new agencies I took on. We turned on all channel recording on their monitors. Like, I want to see all your channels because I want to be able to see that I can see electrical activity, I can see pleth waveform,
Yep.
and I can see your end tidal.
Your
And
cabinet.
through all those things, I can say, yes, the patient had electricity in their heart, waveform, pleth wave. I can see they've got a pulse, and capno, I can see that they're breathing.
Mm-hmm.
So I have objective data to back up what your report says, and I'm happy to go argue that with anyone. Like, I have data to validate your good care.
Yep.
And my opinion is that if anyone doesn't like those recording devices, audio, video, or any telemetry, you want those to prove you're doing good
More is
care.
better always.
Absolutely. And if you're worried about that, you should really look at what type of care you're
Care
delivering to
you're
your
right, yeah.
patients, because I don't care if I'm getting audio recorded, video recorded. I mean, we have police officers in our ER all the time. Yeah. And I want their body cameras on when I'm dealing with a psych patient.
I was just going to say, I'd be the first to volunteer. If you say you want to put a camera in the back of my squad, I'd be like, yeah, okay,
Yeah,
please.
absolutely. Yeah.
I mean, that's just one more CYA for me and my team.
I do see it's another tool in your tool bag from an ultrasound
Absolutely.
standpoint.
Mm-hmm.
I think it's great for getting IV access, but
I was going to say that'd be
at
another
at
reason.
the same point, though, if you need IV access and you need it
Back.
now, ultrasound IV is not your answer.
Then
It's going to be
IO.
IO.
But I also going back to Dopplers, I can use this for ischemic limb too.
Yeah.
And that might be another reason. But
I think if somebody's willing to spend the money and do the training on it, you can find case uses all day long,
Sure.
depending, as long as the medical director is going to
I mean, if
give
you-
the head nod to.
If you want to be really advanced with it, and not that it's 100% true, but you can assess fluid status on patients looking at IVCs.
IVCs, yeah.
All of medicine and ortho kind of has this as their tagline, like, I can train a monkey to do this type of deal. I can train anyone to do ultrasound, right? There's not one thing in medicine, like, you have to be really smart or capable to do this one thing in medicine. It's a lot of small things that we train, and really your value is, like, how much of these small little things do you do? Like, even like reconstituting medication,
Glucagon, yeah.
starting an IV, starting an IO, interpreting ultrasound images. When you learn ultrasound, you're like, oh, that's it? Yeah, that's it. You just have to know what you're looking at.
All right.
Honestly, EKGs are the same thing. You don't get really good experience
Yeah.
until you've seen thousands of them. Well, you need to... I had to do probably 100 ultrasound IVs to get really good at it. And now I'm really good at it.
Now, we'd previously, I know Caleb was excited for years and years and years. NG and OG2 placement has long been a staple of the paramedic in the state of Ohio, and just recently there was a change in protocol that allowed you to do it. So here's your next favorite thing. I expect your shift to be doing this promptly.
After placing them on your ventilator.
After placing your on the ventilator and you've done your NG and OG tube, you're going to place a urinary catheter.
no, that's interesting.
Yeah, so
We do go on,
that's it. But I mean,
enlarged prostate calls and
But-
fluid retentions, and
Does that include suprapubic catheters?
It
or
doesn't. It is ambiguous as I read it. Right.
That's what it
So
says.
urinary catheter initiation and maintenance.
interesting.
So the maintenance of the suprapubic, I guess, is implied there because it is a urinary catheter.
That's vague. That's
But again, this is going to be to the medical director's interpretation, and I can think of
0 medical directors that are going to do that?
Yeah, I don't. Again, zoom out from an EMS perspective. I don't know. I don't know applicability here, but
Inner facilities, it makes sense.
inner facility,
Not emergently,
potentially,
though.
potentially. But again, in hospital,
I was going to say, does that open the scope for the in-hospital providers?
It,
You know what I mean? That's
it opens the scope
Yeah.
for the provider level.
yeah.
Where you're practicing is where you're practicing, right?
Yeah.
So,
I see benefit in it from, let's say that not 911 EMS, but a paramedic out on the road that I know you're having problems with your catheter. I can now send a paramedic out there to place a catheter to fix the problem and avoid an ED visit.
And hospital visit.
okay, so you're looking at it. I was kind of going down for like if you're working in hospital, you're looking at it from the
Even from
But
like,
in hospital
community
works too. 'Cause
community
there's-
paramedicine. Yeah.
Yeah.
I mean, but even I guess I don't want to say this, but even we have skilled nursing homes. If they call us and say they scan the bladder and it's full and this guy cannot get urine out, I guess you could now have a sign off and that hey, we got the catheter for you. We're gonna. I don't like it.
Yeah, but I guess from that standpoint, one of my answers is going to be if you're coming from a medical facility that has that, they should have people there that can fix it. It shouldn't be a call to you. It's a little different that if it's a call from home, right? I'm going to send out the paramedic to go out there because I know this person has an issue and all they need is a urinary catheter, and I'm going to see him tomorrow in the office. That might fit a little bit. I'm okay with it. I mean,
Yeah,
it's first thing you do one of the first things you do as a medical student is you're putting in urinary catheters on your surgical rotation. So
I guess I'm with you. I'm okay with it, but I don't see a need for it in EMS. 911 EMS. I agree with that.
Generally no. All right, so the ones that, and these are common sense things. I don't think you guys are going to push back. So added competency, oral Zofran and Estran for patients 12 years and older for, drum roll, the EMT level provider.
hey, that makes sense.
Now that does make sense, right? Again, safe and effective drug. Now
Especially in oral form.
especially in the oral form. So I looked at this, and obviously these are on the added competencies, and they're doing them they're printing them in order. So it's like, ooh, I look at the bottom ones on the bottom, and these are the most current, right? But that triggers the next level of thought here, which is in the state of Ohio, up until just minutes ago, the advanced EMT also was boxed into giving oral Zofran. However, in addition to this change, I am very happy to see that the advanced EMT has now no guardrails put on Zofran. So whether that is the oral or the intravenous route. And so Nextran, Danstran on the approved medications for the advanced EMT, a certified EMT may administer ondansetron for patients 4 years and older. All they did was put a very reasonable, in my opinion, age restriction on there. The concern all along was QT prolongation with the IV form of that.
Yeah, and honestly, from my standpoint, and I know that we've added it to protocol, but in the pediatric population, we're not very concerned with QT prolongation. I'd be more concerned if they're a complicated patient and they're on medications already. Like, I hate to use the nomenclature you use, like, are they a normal kid? Like, are they a kid that doesn't have any chronic or complex medical problems? Zofran's going to be 99.9% safe.
And I guess I butted those two comments up, and they were separate, right? So the long-standing concern with use of Zofran in all comers with all age groups with the advanced EMT was QT prolongation.
Yeah.
So less the pediatric.
And my point is, like, it's going to be way more likely that either you're going to have an adult patient on a medication that's already altering their QT, or they have some underlying structural issue with their heart that they have a prolonged QT that we want to get cardiology to. I had a patient very recently who screening EKG showed their QTC was 560, and they were in there for nausea, vomiting, and I felt bad that I couldn't do
much, right?
Yeah,
Just do the alcohol prep.
I mean, we tried other things, and we're trying to get her trying to also get her home too. And like, I don't, knowing that you have a prolonged QTC, and this is new for you, but it's on my EKG, I don't feel comfortable sending you home with a prolongating medication because there are stories out there of home individuals or people even going to multiple EDs getting these QT prolongations and then going to a dysrhythmia, and that's what I don't want.
Yeah, going to torsades or
so
DTAC.
I get very concerned with that. We got repeat EKGs that showed clearance. I will throw out that one EKG that maybe that QTC was wrong, and even just looking at eyeball tests, it didn't quite look long to me. But multiple EKGs afterwards show it was new. Okay, we'll still have you follow up with cardiology.
Yep. Hey,
I had this, but I feel more comfortable giving you this medication. Going home.
A QTC that long boxes you out of a lot of standard options.
It does, and really, if you're right at the 500 limit and it's new, I might roll the dice.
Understood.
For in your own brain, think that might prolong it another 10 milliseconds if I use a single dose of Zofran. But once you get near 600, it's a hard no for me.
Right.
It's a hard no for us at 500. It's a hard no for me at 600.
Yeah.
But homegoing is again different. Like if you're, I don't know I don't know why your QTC is prolonged. I don't know what's going on, so I want to avoid it. I'm okay doing that safely in the emergency department because I've got you on a cardiac monitor while I'm giving you this medication. But that's the big concern. Then again, unlikely that the normal kid in normal health is going to be on medications that prolong, let alone have some structural defect in their heart to cause them to have a prolonged QTC at baseline. I don't check EKGs on pediatric patients before giving them.
Even should I admit this on camera? Even a lot of times, if there's an obvious source of the nausea and vomiting, they may get the Zofran for me before I get an EKG, right? If the story's not there, I don't get all wound up. Will I do it? Of course, because I don't want it to be, I don't want it to be, something cardiac related, just manifesting itself as only nausea and vomiting
but then
in my
again,
care,
I mean,
and I miss it, right? But if the
to
story,
his point, if you're a good medic and you give it even before, you're still going to get the EKG and still monitor their rhythm throughout transport.
Correct.
So if something was to come up, I mean, you would hopefully catch it at that point.
Correct. Now, the time that in my mind, right, I've got that homegoing cancer patient who's already, who's gobbling Zofran or Reglan or whatever they're. All right, that's a whole different story, right? Again,
Absolutely.
That story lines up for me. Now that's in the back of my mind. I'm going to shoot this EKG before I continue to address that. But hey, I had a bad burrito and I've been crapping and vomiting for the last 12 hours. That resonates completely different, right?
Absolutely.
Than a homegoing cancer patient, right?
Yep.
So
I mean, but geez, it's pretty easy to get ondansetron prescribed. My wife had a shoulder injury or whatever, and they gave her some medications for the pain, and they followed it up with here's a whole bunch of Zofran. It's like, fill that.
Yeah.
Yeah. I think a lot of people that have it for themselves as well.
Yeah,
It's one of those medications that almost most people should have at home, and
Yeah.
honestly, should be pretty ubiquitous. I don't think it should be over the counter. I think you still should have a doctor prescribes it. To that point, I think that more primary medical providers, and I do it when I'm acting as that because ED doctors act as PCP sometime. But if I'm,
are you kidding?
I know.
I didn't,
Put on your surprise
I didn't know
face.
this. Oh, speaking of which,
I write it. I write it pretty freely because and again, that's going to avoid another ED visit. Man, I keep vomiting.
Correct.
Yeah.
I don't. Did you try anything at home? No, I don't have anything. Like, well, let's nip this in the bud next
Exactly
time.
right.
If you
Yeah.
just get better after some Zofran, like let's have that in your quiver at home. I do want to see you if you. I tried Zofran. I'm still vomiting.
Yeah.
I haven't been able to keep anything down. I haven't peed in the last 12 hours. Yeah, absolutely. Come see the emergency doctor. Will take.
But
care
I think
of you.
also, you would follow that up with don't freely give this to anybody else that has nausea and vomiting. They need to get their own.
Absolutely.
Yeah.
The other thing that got worked in here, and this was earlier in the year, but we're just kind of talking about this now, is for the advanced DMT is in addition to the paramedic provider, is buprenorphine for the withdrawal symptoms from opiates.
I think I know who was behind that one.
So
Singer?
yeah. So again, we've got some pilot programs in UH for the administration of bupe after if they come across a patient having withdrawal symptoms. So turns out we've got not one but 2 episodes tackling that from different different angles where that comes up. So if you're interested in that, that's the thing.
The one that's released is harm reduction.
Oh, that's right.
And then the other one hasn't even been released.
That's right. I forgot. I'm sorry. That will be here shortly.
Yeah.
Maybe actually it might be
the following month.
The month following this. So stay tuned. There'll be a whole bit on it. And then lastly, the other thing I noticed on here as the 2-day change. Again, kind of a common sense thing in my mind. I'd like to hear your all thoughts on that. Is the advanced EMT is now allowed to do a tracheal tube or a tracheostomy tube replacement. Again, if you're that's
as an added competency, absolutely.
Yeah.
It's not an added competency. It's a basic competency, which is even better.
Okay.
Again,
do they get training in that though?
I would think the common sense kind of view of that is if I'm training you to pass a endotracheal tube, I can extrapolate that enough to, putting the obturator in there and putting in the.
I don't know that it's in curriculum though. It might need to be now. I can't.
It probably is now, but I haven't done an advanced class.
Neither have I, and that's where I'm saying.
Okay.
Yeah.
I'd have to find out. I know I can talk to the.
My guess is it's
instructor.
probably going to be if
it's in here now.
Gone,
Yes. Yeah. Whether it's in Nancy Caroline's book, I know that it's in the. I think there's a blip about it. I'd have to go back and look. I think that there is Nancy Caroline for sure. Bledsoe, I don't know.
People freak out about suctioning a trach, and
please suction your trachs.
Yes. Oh my goodness.
I don't know why.
Yeah, I get it's icky and gross, but so is
is
suctioning an endotracheal tube, but it's also life-saving.
Yep.
Yeah.
But how often do we go to nursing homes because they need suction?
Often.
And respiratory's there, not suctioning.
Or
just
if there's not
desatting.
respiratory there, yeah.
And that's not a knock on them. I just think that
you're not suctioning deep enough if they're not coughing.
Right.
But anyway, so I think that's kind of a nice add. We don't have to rely on a paramedic being there
for sure.
Or that also opens the window for them if the trach comes out or it's unusable to insert an endotracheal tube, right?
Yep.
So, I think good choices. But
see, I was secretly hoping they were going to add in IM Solumedrol for the basics.
Yeah, you want to get there, don't you?
I really do.
I think there's other things we should tackle first, but
it's the one drug that changes outcomes for COPD and
it
asthma
sure does.
patients. So
it sure does.
It changes admissions, need for admission. It changes time in the hospital. It changes ED disposition.
With its safety profile and with that door being open for IM, that needs to be on the.
And
I would argue IM Epi is a more dangerous drug than IM Solumedrol.
Dangerous, yes. Also necessary to.
Also life-saving.
More
life-saving.
More immediately life-saving.
Correct.
I think
and if you want to hear more to that, Dr. Regina Yaski did an awesome episode with us talking specifically about outcomes in the ER for peds for that, which, like you said, the admittance went way down.
Yep. So I guess kind of in summary, one of my frustrations as an administrator is I often have people reaching out, can we do this? And
Trigger.
It's it is defined now. That needs to tie back with what your medical director is allowing you to do from a protocol standpoint. Those are two different things. I often have to answer questions like that in 2 ways, right?
Yeah.
State says this. I don't know what your medical director says because I don't know your
I'm
medical
not
director.
him.
Yeah. I'm not him or him
Yeah.
or her or whatever.
Yeah.
So,
but I think most medical directors, and I got this question very recently because I'm onboarding newborn, like, where do you stand? I'm like, top of your license. The answer is going to be top of your license. Whatever you're going to ask me, it's going to be, I want you operating at the top of your license.
Yep.
So I want you to do all those things. I'll be happy to train you on all those things that we need training for, and I think most of us are going to be that way. Obviously, there's going to be a few caveats, but...
yep. So, all right. Well, I think that wraps us up, and we'll catch you all next time.